Part 2. Open treatment. It consists of open reduction and internal fixation or direct skeletal fixation. In open reduction, the fracture site is surgically exposed and the fracture is reduced under direct vision, and the fractured fragments are immobilized by different internal direct fixation methods. Open reduction and internal fixation is now considered the main method of treatment of mandibular fractures. Indications: displaced and favorable fractures, multiple fractures of the facial bones, fractures of an edentulous mandible with severe displacement, delay of treatment and interposition of soft tissue between non-contacting displaced fracture fragments, special systemic conditions contraindicating intermaxillary fixation, malunion. Depending on the planned method of internal fixation and the site of the fracture, three different surgical approaches to the mandibular body with slight modifications are possible: intraoral, extraoral, or combined access. Methods of internal fixation: osteosynthesis. We have intraosseous or transosseous wiring. It is the direct skeletal fixation of two or more bone fragments with the aid of wire ligatures pulled through previously drilled holes. It considered a non-rigid fixation method. And this is the picture of this method. And here is other pictures of this method. And here is pictures of upper border wiring and transosseous or lower border wiring. Other method, mini plates. These are the most common form of internal fixation used in the management of mandibular fractures. They provide semi-rigid or load-sharing fixation. The mini plate principle involves placing the mini plates in anatomically correct position. The plate can be anchored using only the outer cortical bone with so-called monocortical screws, which are 2 mm in diameter. And this is the clinical pictures of this method. And here is other pictures of mini plate method. And radiographic picture of mini plate method. Other method, three-dimensional titanium mini plates. They are based on the principle of the quadrangle as a geometrically stable configuration for support. The plates are adapted to the bone and are secured with monocortical self-cutting screws, as we see in this picture. Other method, non-compression rigid plates, reconstruction plates. These plates provide rigid or load-bearing fixation. They are mainly used in the management of infected, severely comminuted fractures, in fractures where there are continuity defects, and in fractures in which delayed union or non-union has occurred. They require bicortical screws and are fixed in place at or near the lower border of the mandible in order to avoid damage to the inferior alveolar nerve and the dental roots. Compression plates. These plates provide rigid fixation. The principle of compression plating is by transforming the downward force of screw insertion into a compressive force. This type of plates doesn't offer much advantage to the patient in the treatment. Another technique, lax screws. In oblique fractures, compression lax screws can be applied without plates. They are placed perpendicularly across the fracture line in order to avoid displacing the fragments. This technique appears to be ideal for parasymphysial and symphysial fractures, but it becomes technically more difficult in body or angle fractures because the risk of damage to the inferior alveolar nerve increases. And this is other pictures of this method. Other method, bioabsorbable plates and screws. These are made from materials that undergo degradation, so they don't have to be removed after fracture healing. They are mainly indicated in pediatric fractures. Teeth in the line of a fracture. Teeth in the fracture line may cause infection of the fracture site either from the oral cavity by the distributed periodontium or directly from an infected pulp or a chronic apical infection. Infection of the fracture site will result in protracted healing or even non-union. Absolute indications for removal of a tooth from the fracture line: longitudinal fracture involving the root, dislocation or subluxation of the tooth from its socket, presence of periapical infection, advanced periodontal disease, already infected fracture line, acute pericoronitis, where a displaced tooth prevents reduction of the fracture. Relative indications for removal of a tooth from the fracture line: functionless tooth that would probably eventually be removed, advanced caries, doubtful teeth that could be added to existing dentures, otherwise teeth that are structurally undamaged and potentially functional should be retained and antibiotics administered. Teeth in the line of fracture should be followed up for 1 year and should be endodontically treated. There is demonstrable loss of vitality. If fracture becomes infected, immediate extraction should be performed. Complications of mandibular fractures: misplaced fixation, damage caused by misplaced fixation devices like transosseous wires or plates. The risk of damage to structures within the body of the mandible like the inferior alveolar canal and root abscess is less when using monocortical screws. Infection of the fracture site. The main contributing factors are compound fractures with gross contamination, inadequate stabilization of the fracture, loose fixation devices, immunocompromised patients, for example, diabetics and alcoholism. The principles of management are: control the infection, incision and drainage and antibiotics, remove any focus of infection, teeth, sequestra or plates and screws, optimize the healing environment, patient's health, oral health, immobilize the fracture. Other complication is nerve damage. Anesthesia or paresthesia of the lower lip as a result of injury to the inferior dental nerve is the most common complication of a fracture of the body of the mandible. Damage to the inferior alveolar nerve can also result from treatment, which is most commonly associated with open treatment. Facial nerve damage may complicate some fractures of the ramus and condyle either as a result of penetrating injury, severe branch of the nerve, or blunt trauma. And we have late complications like malunion, delayed union, non-union, complications associated with internal fixation and sequestration of bone. Mandibular fractures that require special considerations like pediatric fractures. Fractures of the mandible are uncommon in children, and some modifications to the principles of treatment are necessary when the fracture occurs in a child. The main characteristics of mandibular fractures in children are: bone in young children is resilient and the green stick fracture is more likely to occur, and there is a greater risk of damage to developing teeth. Mandibular fractures in young children heal very rapidly, and some fractures are stable within a week and firmly united within 3 weeks. Treatment is generally of a conservative nature. Mandibular fractures may disturb the growth of the mandible if uninterrupted, permanent teeth or teeth germs are lost. Fractures of the condyle require special consideration. When fixation is needed in very young with uninterrupted or very few deciduous teeth, a splint for the lower jaw alone may be used. This is constructed as a simple acrylic and retained by two light circummandibular wires. When sufficient firm, erupted, deciduous, and permanent teeth are present, eyelet wires or arch bars can be used. When there is significant displacement of fragments, open reduction and internal fixation may be necessary. In this situation, any plate or wire fixation must be strictly confined to the lower border to avoid damage to developing teeth. Slight imperfection and reduction can be accepted when a fracture is treated because continuing growth and eruption of teeth will compensate in most cases for the imperfect alignment of the fragments. Prolonged follow-up is required in order to be sure that there are no long-term effects on both mandibular growth and the normal development of the permanent dentition. Fractures of the condyle. Fractures involving the mandibular condyle are the only facial bone fractures that involve a synovial joint. Many classification systems have been proposed for fractures of the condylar region. Generally, they can be classified into fractures of the head of the condyle, intracapsular, or the neck of the condyle. Treatment of condylar fractures. All intracapsular fractures and all fractures in growing children should be treated conservatively. Immediate or early immobilization should be encouraged. However, if the occlusion is distributed, intermaxillary fixation is applied and maintained until stable union can be expected to be present. The period of immobilization should not exceed 10 to 21 days. Open reduction and internal fixation of condylar fractures. We have absolute indications, displacement of condyle into middle cranial fossa, impossibility of restoring occlusion with closed treatment, lateral extracapsular displacement, invasion by foreign body, for example missile, and we have relative indications, bilateral fracture with associated mid-face fracture, particularly where one condylar fracture is dislocated or angulated, bilateral fracture with severe open bite deformity, unilateral fracture with dislocation, overlap, or significant angulation of the condylar head when intermaxillary fixation is contraindicated for medical reasons. Surgical approaches for open reduction and internal fixation. The main approaches to the TMJ are the pre-auricular, submandibular, retromandibular, or transparotid approaches. The intraoral approach has the advantage of avoiding facial scarring and risk of injury to the facial nerve, but the major disadvantage is limited access. Minimally invasive endoscopic repair of condylar fractures offers less morbidity and operating time as well as quick patient recovery. Fixation methods in open reduction and internal fixation. Among the fixation methods that have been used are transosseous wire, Kernesher wire or K-wire, mini plates, lac screws, bioabsorbable plates, and pins, and more recently ultrasound activated resorbable plates and pins. Complications associated with condylar fractures: malocclusion, limitation of range of movement, displacement of the disc, reducible or irreducible, chronic pain associated with dysfunctional movement or with osteoarthritis, ankylosis of the TMJ. Fractures that involve the joint space, particularly in young patients, seem most prone to result in this complication. Ankylosis can be fibrous or bony. Predisposing factors include age, The major incidence is below the age of 10 years. Type of injury: intracapsular trauma with crushing of the condyle, damage to the disc. Disruption of the disc is likely to occur in two particular types of fracture: a severe intracapsular compression injury or a fracture dislocation. Disturbance of growth in children: when the fracture involves the condylar cartilage and the articular surface, subsequent disturbance of growth may occur. The effect of damage is failure of development of the condylar processes and a smaller mandible on the affected site. And here is some pictures related to complications associated with condylar fractures. Fractures of the edentulous mandible. The physical characteristics of the mandible are altered considerably following the loss of teeth. The alveolar process undergoes resorption and the mandible becomes atrophic and thin. The resistance of the bone to trauma is further reduced by changes in the structure of the bone associated with process of aging. The blood supply of the edentulous mandible is more periosteal due to the diminished endosteal blood supply of the mandible. The healing potential of the bone is reduced and the healing of the fracture is a slow process, and the complications such as a non-union are more likely to occur. Smaller cross-sectional area of bone at the fracture site and the absence of the stabilizing influence of teeth. Fractures are much less frequently compound into the mouth than when teeth are present. As a result of, if treatment is by closed reduction, the risk of subsequent infection is much reduced. Treatment: antidisplaced fractures require no active treatment. The edentulous mandibular fractures can be treated by closed reduction using the conic type splints, or if the patient is a denture wearer, the dentures can be modified to allow intermaxillary fixation, which can be used as a splint. When open reduction intermaxillary fixation is required, reduction should be made with minimum exposure of the fracture site to minimize interference with the periosteal blood supply. Autogenous bone grafting may be needed in very thin mandible. It must be remembered that accurate anatomical reduction is not required, as any inaccurately is easily compensated by adjustment of dentures, and that in very thin mandible stable fibrous union may be an acceptable result in that very old or infirm patient. And here are some pictures related. Comminuated mandibular fractures. Comminuated mandibular fractures result from high energy injuries such as missile injuries. These injuries are associated with soft tissue damage, and many of these fractures are open, compound, and contaminated. The open fragments are often difficult to manipulate and secure while maintaining their soft tissue attachments, and are therefore at risk of becoming loose or devitalized later on. A traditional method of treatment of these fractures used closed techniques, thereby avoiding periosteal stripping and further devitalizing the bone. Recently, open reduction and internal fixation has been advocated to provide load-bearing fixation and stability across the fracture. In severe injuries after airway and hemorrhage control, temporary intermaxillary fixation or external fixation can be used until definitive open reduction and internal fixation. And thank you.